Today we're going to talk about testosterone in women, or androgens in women. And like Anna said, I was a breast cancer surgeon, and that's where my story begins. And no one here, none of the presenters are going to agree on everything. And that's okay. It doesn't mean somebody's right and somebody's wrong. It depends, and that's what makes these conferences exciting. We're going to talk about testosterone's function in women, the age decline of testosterone in women, and how that parallels the age decline in men. We're going to talk about symptoms of testosterone deficiency. I'm going to talk about the testosterone therapy by the implant, why I like it, and how it works. And then I'd like to thank Dr. Rosier for introducing my next subject of this talk, and that's testosterone and breast cancer. Then we're going to talk about the combination of testosterone with an aromatase inhibitor, and is there any place for this hormone therapy in breast cancer survivors? And then if we have time, I'm going to go over my protocol on how I treat women. If we don't have time, these slides are in your syllabus, along with some of my most critical handouts that I give patients, along with the protocols for both men and women. So all of that should be in your DVD. I do have a website, hormonebalance.org, and it is totally nonprofit. Anything on this website can be used in your practice. You can copy it. Some of them are Word documents that you can change to fit your practice and your patients. But the reason I'm bringing this up now is the data section of my website. I also believe in evidence-based medicine. There are over 4,000 full-text articles on my website. Every single article I cite today is full text on my website. It is password protected because of copyright laws. So you go to the data section, the username is data, and the password is data. Okay, 1 in 8. How many people here have breast cancer or a first-degree relative with breast cancer? How about a friend? How about a friend, first-degree relative, or second-degree relative? Wow. Do you know the incidence of breast cancer when I went to med school? Do you know what it was? It started out, before I started med school, at 1 in 30. It was about 1 in 24 when I was in med school. It is 1 in 8. And you're right, someone else mentioned today, genes don't change in 50 million years, okay? I want you to think about a new paradigm throughout this talk. And I just want you to think about this as women do not equal estrogen. Should the estrogen have ever been given as the sole hormone replacement therapy? And if you think about estrogen's action at the estrogen receptor alpha, is that what hormone replacement is really about? So I just want you to keep that in the back of your mind during this talk. Okay, testosterone's function in women. It is one of the most under-investigated things in the entire United States. The only data that exists is on sex drive and libido. But guess what? Where are androgen receptors located? They're located in the brain, spinal cord, and nerves. Testosterone is extremely nerve protective. In fact, the first person I ever put testosterone pellets in was my dad. My dad, who had Parkinson's disease, and that's why I actually researched the subject. Okay? It made a tremendous difference in him. And he had been on sublingual testosterone. He had been on the gels. He had been on the injections. And nobody wants to give their dad weekly injections of testosterone. So I looked into pellets, and what a difference it made in his quality of life. In my current practice, the biggest difference I see in MS patients, do you know what I mean? Alzheimer's and memory loss are with the testosterone pellet implants. There's also androgen receptors in the bone, muscles. Everybody knows that. It's an anabolic hormone. It increases bone density. It strengthens muscles. It gets rid of fatty or adipose tissue. There's testosterone receptors or androgen receptors in the heart and blood vessels. It's a vasodilator. It's cardiac protective. We already talked about the androgen receptors in the breast, and I'm going to readdress that later on in this talk. There's also androgen receptors in the uterus. Okay? They used to use testosterone to treat fibroids and endometriosis. Because again, just like in the breast, it balances the estrogen effect at the uterus. There's androgen receptors in the ovaries, vaginal tissue, bladder. We see full reversal of incontinence with the testosterone pellet implants. The urethra, even the lung and intestinal tract has androgen receptors. So to think that testosterone's only function is sex drive and libido, that doesn't even make sense. And these androgen receptors are present in both males and females. Testosterone is not a male hormone. In addition, testosterone is a major substrate for estradiol. It gets aromatized to estradiol. Every single cell that has estrogen receptors has the enzyme aromatase. Okay, this slide is from one of my research partners' articles, Konstantin Dimitriakakis, and the only reason I show you this is you would be surprised how many physicians, gynecologists, don't understand that when you're a healthy young 20-year-old female, you have 15 to 20 times more testosterone than you ever had estradiol. And nobody pays attention to testosterone in women in the US. And testosterone, as you see, declines with age. In fact, a 35 to 40-year-old female has half the testosterone as a healthy 20-year-old female. And this is the age when symptoms start. When I was a breast cancer surgeon, I would get young females, of course I was that age myself at the time, come into my office with breast pain and tenderness on their antidepressants. And I knew it couldn't be right. You don't suddenly hit 35 or 40 and end up going on antidepressants. But if you look at what happens, your testosterone has declined, and we see symptoms starting at that age. Those symptoms are not related to estrogen levels. What are symptoms of androgen deficiency? And it might be referred to as relative androgen deficiency, especially in the European literature. You have a diminished sense of well-being. You just don't feel good. You have the anxiety, irritability, depression. That's huge in both men and women. So a lot of these things are the same or true in men also. You have low energy, physical fatigue, lack of motivation, lack of self-confidence. Women in particular, but sometimes men, become fearful. Another thing that I've used testosterone pellets for, testosterone implants for, is people with post-traumatic distress syndrome, and it helps tremendously. You also get, this is big, the memory loss, changes in cognition, and it works unbelievable for that. Bone loss, decreased muscle strength, hot flashes, both men and women, sleep disturbances, insomnia, waking during the night, and obviously the decreased libido. How many people here do testosterone implant therapy? Okay, good. Good, that's actually more than I thought. How many people here have never heard of pellet therapy? Okay. Testosterone pellet implants, things that patients might say or other physicians in your local community are they're not FDA approved. Testosterone pellet was FDA approved for men in 1972. It's the only licensed form, until recently it was the only licensed form of testosterone in England for women. It's been used in females in the United States and Europe since 1938. The normal female dose is 50 to 225 milligrams. Those doses have been studied extensively in the literature. And I can tell you that 50 milligram dose is way too low, but those were in the studies. In the old days, they used to give testosterone in addition to an estradiol implant. I no longer do any estradiol implants because of the side effects and the complications with them.